Hello, I'm Louise Baglow. I'm the Director of Professional Services and Development at the NPA. I'm really delighted to welcome you today to our first Pharma webinar. It's great to have had so much interest, and for those that have come today, I'm really pleased that you are here to share our insights and health and all the information about the healthcare landscape. At the NPA, we really do value the role our industry partners play, and they provide us with some support for our community pharmacists to provide better patient care and access to medicines, and obviously better patient outcomes. Independent community pharmacy has grown and represents the majority of community pharmacy, and that's a really important point. We've got a really great lineup today, which I'm going to share with you on the next slide. And with lots of information and insights from my esteemed colleagues. So I'm just going to run through a few of this through the agenda. So we've got an introduction from me, and I've got a couple of slides, and I don't want to go on too much about the NPA because I think a lot of people here know a lot about the NPA, but sort of that will probably act as a reminder. The stars of the show, we've got quite a few today. We've got Dr. Jill Loader and Mr. Michael Lennox, who are going to give you an overview on the healthcare landscape and the NHS structures. So that'll be running for the majority of the session. We've got Q&A. So if you would like to put some questions within the Q&A or the chat, we will field those questions. And we've got not only our speakers here today, where we're joined by Gareth Jones, who many of you will know, who's our Director of Policy and External Affairs. We have got other stars of the show, including Sanjay and Matt, who will really talk to you about how you can work with the NPA. And we're introducing something called the VIPP programme. So Sanjay will introduce you to that. And I will close the session at 2 o'clock because I know time is valuable for yourselves. So the National Pharmacy Association. So who are we? So we are an organisation, we've been around for over 100 years. We began in 1921 as the Retail Pharmacy Union, and we've grown to become the leading voice of independent community pharmacy. We have lots of aims, but they're really all about pharmacy. We're supporting community pharmacy both commercially and professionally. And a little bit about ourselves. So we are a membership organisation. We're multifaceted. We've got lots to offer. We have an insurance arm, which is a gold standard offering that we provide in the marketplace. We have won an award in March 2025 for our insurance in the specialist coverage category at the National Insurance Awards. So we're very proud of that. We're proud of the pharmacy and advice and support function that we have. We have 12, actually, or there might be more pharmacists that actually provide support to our members. So they provide anything from any sort of advice that you might actually need in relation to pharmacy and helping their business grow. So we will provide information to pharmacists, and they can just literally pick up a phone and speak to a real person, which is great. Gareth supports all the external affairs and advocacy, so we will lobby on behalf of our members. And I very much head up the learning and development elements of our offering. And we have thousands of students on our books in relation to community pharmacy. We are obviously a trusted and established partner. We've been around a long time. And in essence, this is, we talk in all different sectors, and we have got a huge offering. We are a not-for-profit organisation, which I think is really important because, in essence, we reinvest any of the monies that we make into our membership. So we're here for growing our membership and our offering. And the sentence on the side of the screen is all about sort of partnership. We want to partner to be the partner of choice. We want to deliver improved patient outcomes. We want pharmacists to have all the experience to drive professionalism, education, expertise, and obviously be patient-centric. So we are here to drive our community pharmacies and drive patient outcomes. I'm not going to dwell too much on the following slide because I know you want to hear from Jill and Michael, but really there's a lot of ways that you can partner with the NPA, and both Matt and Sandra will talk about this a little bit later. But we are the largest membership base. We have 6,000 member branches, and we have over 2,000 customers. So we represent about 65% of the market. We can provide full market access using our different colleagues like GPs and Practice Managers Association. We will support growth of OTC and ethical products and information and above the line where needed. And also we will support looking at different life cycles. And it really, if we'll hear about the 10-year plan in a minute. And in essence, it's really supporting pharmacies grow and actually improving patient outcomes. You can utilise the NPA to host delivery of pharmacy messaging, training and education. We will engage with providers to provide education for our teams, and it sort of complements what I do in my day-to-day job. We really looking at new patient pathways and how we can actually sort of break the mold and deliver better access to medicines. And obviously we will support with NHS stakeholders. So there's a lot of reasons why partnering with the NPA is good for you and good for us. So without further ado, I'm going to pass you over to both Jill and Michael. They'll introduce themselves and they will talk to us about the current healthcare landscape. So over to you guys. Thank you.
Hello, Jill. Did you want to go first or shall I? I'll go first. Hi, Pharma colleagues. Really good of you to join us today. Really excited about this time together. Look, my name is Michael Lennox. I'm proud to be a NHS community pharmacist, have been since 1986. How is that possible? I hear you say 39 years. That went quick. But my passion is for patient care through great pharmaceutical care. And all through my career, I have worked strategically, clinically, and also in tandem with great colleagues from Pharmaco as well, because goodness, if Pharmaco and pharmacy can't work together, who can work together? So I'm really excited about sharing with you some stuff on behalf of the NPA pertaining to the direction of travel of the construct of the NHS and what we think that means in the NPA and how we think we can navigate that. My colleague Jill, who hopefully is now on speaker. Okay, Jill's not on speaker, but what I can tell you is that Jill will give an overview of the current healthcare landscape, talking about the kind of the changes that are in play, and then after I do my bit about the construct of how the new NHS is forming, what we'll have is Jill wrapping up with a kind of a session on, so what does this mean? What's coming next? And concluding. So look, the half hour together will go really quickly in principle. Jill, are you there yet?
Yeah.
Excellent. Introduce yourself and crack on.
Can you hear me now, Michael?
Sure can.
Great. Okay. Thanks very much. I'm Jill Loader. I've been working in the NHS for 35 years. I was previously responsible for pharmacy commissioning for NHS England and then for pharmacy strategy and policy for NHS England. And I've had a number of roles in the NHS in strategic health authorities. I was even involved with the Landsley reforms and setting up the NHS Commissioning Board as it was back then. So yeah, I've had a lot of NHS experience, and I'm now working with the NPA on NHS as a lead on NHS contract reform, alongside Michael, whose expertise is in integration with the NHS. So we're the kind of NHS facing team within the NPA.
And Jill, I'm sure our lovely guests would like to see you in the pixelated flesh, so to speak. Is your camera coming on?
I seem to have managed to lose that in the getting my microphone to work, but let's just carry on.
Yes, of course.
So just taking you through an overview, what we wanted today was to try and the NHS and the operating framework and the organisations, things are moving very, very fast, and it's difficult to keep up with even when you've been embedded in the NHS for years, let alone if you're looking in. The first slide here is on the global context, and I'm sure you're well aware of the global context, but the capacity, the demand for NHS services and the capacity constraints on NHS services are really real. Wanless told us quite a long time ago that we needed to do something about the public health. And actually, we're in one of Wanless's worst case scenarios now. Can I have the next slide, please? Next, thank you. So the context in the NHS, I've listed a whole load of documents that are coming out from the NHS recently, starting with the continued delegation. So there's a huge move from central to local. So throughout my career, I've seen the NHS move to central control and move back to local control. We're in the middle of a very big push at the moment to devolve decision making to local. That started with delegated commissioning, and actually delegation of commissioning like general practice, pharmaceutical services, dentistry, optometry, and others happened previously. But this year, from the 1st of April, specialised commissioning has been devolved to ICB, so devolved to local decision making. The Aradazi review and the 10-year plan consultation were launched, and so actually the neighbourhood health guidelines were launched back in January this year. So I'll take you through some of those documents because they're impenetrable sometimes, and also the NHS England website is impenetrable in finding them. But what we've seen recently is a real appetite from the Secretary of State for massive reform in the NHS, and none bigger than really the Health and Social Care Committee, who gave Amanda Pritchard, Julian Kelly and Stephen Powis a very difficult time. And notably, all three of them were out of post very quickly after that, alongside others like Emily Lawson, the Chief Operating Officer of the NHS. So we've seen a real big change in leadership, and we've seen some really big news around NHS England ending and the being subsumed into the Department of Health. So the Lansley reforms have really taken a complete about face, and there's a real appetite to put more of the money for NHS services and more of the decision making for NHS services at the front line and take that away from central control. Can I have the next slide, please? So what's the national context? Aradazi really found the NHS to be in serious trouble. His letter to the Secretary of State made really quite difficult reading. The health of the nation has deteriorated. Waits for everything has deteriorated. A&E is in a dreadful state. Cancer, we're lagging behind other countries in terms of our outcomes. Cardiovascular disease, the outcomes are going in the wrong direction. The money's in the wrong place. We're trying to move more care into the community, but still hospitals are subsuming a lot of the NHS budget. And the patient voice is really not loud enough, and staff are disengaged. So it was quite a picture that Aradazi painted, but there was hope within that. Can I have the next slide, please? And really, just to put Aradazi's findings into context, this is the Collins report from the Lancet in 1950, which talked about the state of general practice being absolutely dreadful and deteriorating, that it being worst in areas where need was highest in some of the industrial areas, and talking about the relationship between hospitals and GPs and how that was detrimental. So this is a problem that's ongoing and has been going on for a long time. Next slide, please. So if you haven't looked at the appendices to the Aradazi report, there was a huge annex that was published with the report, and it's certainly worth going through and having a look at. and it has a huge amount of information that was pulled together very quickly from a huge number of sources. So you can see that trends in life expectancy at birth are decreasing now on a downward trend. Can I have the next slide? And prevalence of long-term conditions is hugely increasing. So morbidity of the population is increasing, and with that, the number of contacts with the health service, the number of medicines they're taking, number of investigations they're having. So actually, we've got a lot of people living with multiple morbidities, and there's a lot of questions about whether the system where we have specialists in areas dealing with different things is better than having generalists, and whether we need to go to a model where we're looking holistically at the patient. Can I have the next slide, please? So what is the mandate for the NHS? So back in January, the government were really clear. It was about waiting times, primary care access, and access to urgent emergency care. So nothing new there, but it's worth understanding that those are the things that are going to be measured, and that the government will see the government will measure themselves against in terms of their success with the NHS. And both Keir Starmer and Wes Streeting have staked quite a lot on the NHS in terms of this is what they're going to fix, and this is part of what they want to do during their parliament. But interestingly, the operating model, the reform of the operating model was trailed back then, and a huge reform of efficiency and productivity. So Aradazi found productivity was not good enough. And Jim Mackey at the NHS Confederation, he's come in with a really big desire to balance the books of the NHS again. Can I have the next slide, please? So the planning guidance was pretty similar to the mandate. It reflected the mandate, which you would expect, but also talked about urgent dental care appointments and talked about mental health, patient flow through mental health, crisis and acute pathways, and also the children and young people's mental health. Can I have the next slide, Helen? So the operating model is starting to emerge, and I'll hand over to Michael for a bit of a walkthrough of what Michael and I are looking at and seeing in terms of new structures that are emerging, in terms of some of the documents that have come out around roles of ICBs, and some of the integrated neighbourhoods, which are going to be really central to a massive change in the way we do things. So over to you, Michael.
Yeah, Jill, thanks. Can you hear me okay, Jill? Yeah, am I coming through?
Yeah.
Excellent. Well, look, thank you to Jill for walking us through the context there of the whys and the what's happening. I wanted to talk about the construct phase now, which we are rapidly entering. I guess before one sees a new thing being built, the old thing is typically torn down, and it feels like we're in a tear down stage, and our heart goes out, of course, to colleagues in the NHS in various structures and organisations and roles at the minute who've served brilliantly over the years, but now find themselves in this period of uncertainty. But Wes has come in, and a wee bit Elon Musky has taken the chainsaw to the existing structures. So yeah, NHS England abolished within 2 years, and the interim team that are in charge of that abolition and reinvention within the DHSC are good people who've really got stuck in. There is real clear national leadership happening, strategy and policy. I mean, obviously there is a complete functional reduction at the minute, and a real elimination of duplication. And it's obvious that, you know, post Lansley, the government are saying that we want our hands on the control levers of the NHS. So yeah, I mean, some great NHS colleagues, of course, centrally and locally will transfer across to the DHSC, and we welcome and we hope to see that, because, you know, we've got many great friends in the NHS. Out in the regions, the regional structure, as we understand it, will remain. So the 7 current regions within the England NHS will remain, and they will be given the job of oversight and performance management of the ICBs. So they will form a kind of a direct connection with the ICBs on the ground, and also kind of then support providers under NHS performance assessment frameworks. That will, to a certain extent, continue. And if we look at the ICBs themselves, they really will be the engine of strategic commissioning and really driving population health management. And of course, what then happens in terms of resource allocation, system accountability, and commissioning, in essence, setting the direction of travel for commissioning for the new model of delivery. And we are going to see merging and clustering to approximately 27 entities. There's a reasonably solid map of what it looks like beginning to form. And again, for dear ICB colleagues out there, this is a very challenging time. A lot of the people that took on the mantle of ICB leadership, of course, though, are go-getters. They are real, positive disruptors, constructive disruptors. So let's hope that genotype that's in ICB leadership already is going to make this formation happen. And then really interesting, look, we've got the whole provider network as well, and how the provider network will be part of the new NHS operating model. This is really interesting. I mean, certainly our NHS trusts, whether they're secondary trusts, mental health trusts, community health trusts, they themselves have been charged with the responsibility of reducing their own costs, their own corporate costs. But there's a wee bit of magic wrapped up in the operating model that's emerging, and that magic seems to be that, if you look at the ICB blueprint plan that Jill referenced in her section, providers are looking to be charged with the responsibility of taking on some of the current ICB responsibilities. We'll have a wee look at that in the next couple of slides. And then look right at the new base model of delivery, where the wheels get traction on the delivery of care. We've got these new local integrated neighbourhood health setups, and these integrated neighbourhoods are really truly going to be where the stuff is made to happen, charged with a responsibility to develop these new ways of working together like never before, and optimizing new models of care across the provider network. So a change to big, you can probably see it from space. Next slide, please. And if we look at a little bit of detail of the ICB operating model emerging, and the content for this is available in the ICB NHS England blueprint, colleagues. So do look at the detail of this when you get a chance. You probably already have done. If we look at the kind of the four key functions in the wheel of delivery, I mean, the first thing is it starts with local context. So although the centre and the Department of Health is going to have the NHS functionality wrapped up within it, actually these 27-ish ICBs or clusters are where real assessment of population needs happens now and future, and where local population demographics and communities will be served. Assessing all the usual quality stuff that wraps around it. So, BDI of ICB looking over the number of integrated neighbourhoods they have under their patch. Yes, developing the longer term population strategy as well. A key thing I think the Labour Party new government are gambling on is the idea that the NHS starts to do the right thing now for the longer term future. Thereby, we end up with a more sustainable, resilient NHS and a healthier country at the end of it. Obviously, the ICBs will be delivering the strategy through kind of payer functions and resource allocation. This may be a personal opinion, but I think the cases for what resources and what approaches are taken will be driven by the integrated neighbourhoods. But the integrated neighbourhoods will then obviously interface with their ICB overlords and bid and pitch and take the money and resources that are allocated to them, making the case for it. And then lastly, of course, the ICB will step back and say, okay, is what we're doing right? Is it working? Evaluating the impact. There is a day-to-day of this as well, like waiting times and any other metrics that are put on the table. We can't get away from that, both politically in terms of understanding where the NHS is travelling to. But there is also this longer evaluation, this kind of value-based resource use, and tracking the improved outcomes along the way. So that kind of quality control longer term are we flying in the right direction? But there's no doubt about it. Local autonomy for delivery decisions will be made, and those decisions will be made based on driving the right outcomes. Next, please. And reading over stuff from Confed last week and scanning the kind of the speeches that were made, particularly by really senior people like Sally Warren rather, and Penny Dash, who are absolutely at the helm of the new NHS and the 10-year plan. Sally said we're taking one hell of a bet on ICBs as the driver for this new NHS. And the other comment that was made, absolutely unprecedented change. So this is not mild. This is big, bold. Here's hoping it delivers brighter along the way, not just for the country, for our populations, but selfishly for community pharmacy as well. We need a new golden age of playing in to deliver as well. But of course, as the ICB bet is happening, their running costs are reduced by 50%, and the amount of funding they have per head of population, they're not going to be rolling in money in any shape or form. And the truth is, they're going to have to try and deliver much via providers. I alluded to that in a couple of slides ago. And these are the sort of functions they're coming up with, which could be transferred to providers. So if you look at kind of the first three, the workforce, the green plan, sustainability, and digital, those are in essence the kind of the drivers, if you like, the enablers of what need to be dealt with. Well, in my experience of being a sort of reasonably senior person in an ICB until last year, those were all shepherded by ICBs. That functionality is now going to be magically found in a way delivered by providers. So there's a lot of unanswered questions about what that looks like and what the motivation of providers might be to kind of take on these new responsibilities. A couple of bits that I think are really pertinent to community pharmacy and indeed Pharmaco is the development of the neighbourhood and the place-based partnerships around it. Now, the NPA are really close to the senior team that are imagining and engineering this place-based partnership creation. And they've been using a term, a classic project term called tight, loose, tight. Now, the tight that's coming out is we're changing the NHS, we're abolishing it, it's going in the Department of Health, how it functions, what it does, how ICBs are constructed, that is not up for debate. You will have a network of integrated neighbourhoods as well. That is tight, that is not up for debate. But the key thing that we'll explore in a moment or two is what the loose is. And the loose is, well, how do you build your neighbourhoods? We'll come back to that. And in the last couple, meds optimization. Gosh, we've been used to a world of, people with steely grips on meds management and meds optimization in PCTs, CCGs, ICBs. And now it's indicated that in time, a great phrase, that will pass over to providers as well. So that can't just be a kind of like an NHS provider. That has implications for all providers, GPs, pharmacy, trusts, etc. And then likewise, the functions which could be transferred to providers include imagining and engineering new pathways and service development programs. Now, obviously, ICBs will retain the strategic overview, but in essence, providers and neighbourhoods will invent the new ways of doing care. And then amazingly too, this idea that the infrastructure and the estates that wraps around the delivery of the new NHS, somehow the mesh of providers will move together to kind of deliver on that in a meaningful way too. So a lot of big challenges wrapped up in that, but it's a heck of a bet, isn't it? And we're going to deliver the 10-year plan and absolutely unprecedented change by having this structure, ICBs, neighbourhoods and providers working differently. Next slide, please. And look, this I pinched from the 25-26 operational plan guidance, and this kind of tattoos the basic image of an integrated neighbourhood. And at its base, and the most important bit in terms of the new ethos, is connecting people, accessing health and care to wider public services, our friends in the third sector, voluntary sector, social care, public health, government, mesh together in a neighbourhood, actually knowing their people, knowing their communities, knowing what they need. And then the second circle, strengthening primary care and obviously community-based care. NHS community pharmacy fits into that so strongly, it's unbelievable. Surely to God, this is the time I get my new golden age of NHS community pharmacy before I hit 40 years worth of service. And then obviously NHS and social care formally working together to prevent people spending unnecessary time in hospital and care homes. That left shift into primary and that preventative kind of community mobilized kind of approach. Good overview, and it's worth reading as a document. I think Jill listed it in her compendium. Next one, please. But okay, so what happens when you build a neighbourhood health service? Okay, we got the 25-26 guidelines, which we're talking about the as is, but the new neighbourhoods are going to be taking on such a bigger, bolder remit. It's unbelievable. And you can read the words on the slide, but integrated working is going to be the norm, not the exception. Again, I talked about the tight. The way that neighbourhoods work together, that they are constructed, is not up for debate. But how you engineer them, how you build them, how you get them together, that is loose. That is dependent upon what you've got at your fingertips in your own neighbourhood, your own ICBs. But it will deliver care closer to home, improving people's access, experience. And it's the whole thing about insurance sustainability, the longer term idea that you can prevent in health, activate patients, and perhaps reduce the tertiary intervention bill that we're facing into. And again, by gluing together, you address the fragmentation that happens, an awful lot of poor communication, duplication, only caring about your own bit of the NHS, the passing patients from pillar to post, and really suboptimal care at the end of the day on occasion as well. It feels kind of a bit, torturous at times in the NHS. But with population health management, modern general practice, which is kind of an official program that's out there at the minute in terms of how GPs will work at scale together in primary care networks. We within the NPA would also like to see a kind of a modern NHS community pharmacy practice. But I'll not steal Jill's thunder because she's going to talk about changes to pharmacy contract next. And this whole idea of multidisciplinary teams where you have the platforms, the processes, the pathways set up, and you get professional people working together for the benefit of patients. The idea that you kind of reorganize where people go to for intermediate care, how you look after them, virtual wards, and the idea that you have urgent neighbourhood services that stop people drifting up to the expensive place to get care, the frantic place to get care, A&Es. This all makes good sense. And again, that focus on those at the pinnacle of the sickness pyramid with the most complex needs. How do you wrap around them to avoid admissions, etc.? So some really big challenges for neighbourhood health service there as it begins to imagine itself. Next, and here's the thing. There's likely to be something like maybe 800 neighbourhoods. So there's going to be quite a breadth of belief and a breadth of construct out there. Now, I really like this model, so I lifted it and put it in. And this is from our friends in London as a region. And I just thought they articulated it really well. We'll have a quick look at it in a moment. But again, just to reiterate, how a patch wires its integrated neighbourhoods is going to be loose. That doesn't mean it's going to be random. There's going to be a kind of a blueprint for integrated neighbourhoods. We believe that blueprint and that programme will have an implementation plan and resources and materials to help people forge these. But look, individually over the country, there are integrated neighbourhoods working quite well already. Thank you very much, here and there. But what we've got to do now is move from here and there to everywhere. London seems to have a real sense of itself. And again, like that 3-circle diagram I showed you a couple of minutes ago, it starts with the resident, their term, not patient, resident. The resident is at the centre of the neighbourhood working, and the teams need to kind of build on the strengths of that neighbourhood, that community, and draw that into how the community and individuals, I guess, activates themselves and looks after themselves better. and navigates the NHS better and appropriately. You then have the hyper-local functions the NHS and London team have coined. And I really like this because, I mean, nothing's more hyper-local than community pharmacy. And I was really delighted to see they put community pharmacy first in their shopping lists. But of course, that includes our general practice colleagues and obviously the voluntary and third sectors as well. And we are the first point of contact for residents as they need to kind of be initially helped for minors or navigated for more complex. You then move into what they're describing as the consistent functions. And this is the kind of the overlay of the next level of NHS services. And these they see as being more consistent across the neighbourhoods. You know, you can't have random times 100 or 800 integrated neighbourhoods. You've got to have a framework. And once you move from that kind of consistent function, you know, where you've got kind of working in primary care, social care, mental health, etc., you then move up to the kind of the tailored functions. And this is where you might arrange yourself differently to do stuff depending on your geography and your population's needs. So again, there's sort of a looseness in that, which is necessary if you're going to make best use of all the bits within your terrain. And then, of course, you get the top end of it with aligned functions where, you know, it's maybe a tertiary or a large secondary care trust or whatever. And you've got, you know, geriatricians, and you've got, you know, a lot of the other specialist areas. But let's be honest, the move out of hospital is going to be mammoth as well. And this, I don't even like the term, you know, out of hospital. I'm much rather flipping it and going, it's in primary care. We're moving to an in primary care model. And that is where pharmacy, working with general practice and others, can really make a heck of a difference, changing where patients get care, changing channel flow, actually freeing up the GPs to do some of these newer functions that they're being charged to do. We're beautifully placed to kind of take on these new roles, and we've been playing and doing that for forever and a while now. Jill will talk a bit more about that in terms of it. So loose on the hows, but tight on the what's is what I've been told. And the what's are the outputs and the outcomes. I think that's me. Jill, back to you for the next slice of, so what's coming at us?
Yeah, so we're really imminent. Thanks for that, Michael. That's really helpful. So the 10-year plan is likely to is due really soon, and it's likely to give us a little bit more detail on how all that is envisaged. Lots and lots of people have contributed. No one has said the status quo is what should happen. And absolutely, it's based on the big shifts that Wes Streeting started out with, which were treatment to prevention, hospital to community, and analog to digital. So everything we're doing, all of the investment in the NHS and all of the operational framework of the NHS is focusing around those three shifts. And we've seen radical reform. I don't know how many times I've written radical in this presentation, but it's all about radical reform. It's all about doing things differently, transformational change, looking at the way we do things differently. A lot of money is spent on the NHS, and Wes Streeting was very clear. It's not about the 3% that happened that came with the spending review. It's about the 103%. It's about using all the money and rethinking the way we do things. Very much the 10-year plan is expected to have an end to top-down control of the NHS. There's already been quite a lot of reduction. So QoF, the number of targets in QoF was reduced and really focused on sort of cardiovascular outcomes. The number in the planning guidance, the number of national priorities is massively reduced. So that kind of control, there's something about letting go of that control of the NHS centrally and nationally and letting people be free to innovate locally. But there will still be, obviously, some oversight of that. There's very much something about leadership and good leadership and stepping in when leadership is not good, and taking over. So that's likely to come out of the 10-year plan. There was announced yesterday in the news a real boost for clinical trials, so that we get real world clinical trials, that we get a lot more people being able to be recruited into clinical trials, to look at clinical trials available for themselves through the NHS app. So real ambition in that area. And I'm really preparing for a future world. So this is a 10-year plan. So preparing for artificial intelligence, preparing for genomics, predictive and preventable medicine, to making sure that we've got an NHS that is fit for the future. So I think that's I mean, it's overdue now. Obviously, some of the NHS leaders speaking at the NHS Conferred Expo have seen lots of iterations, and there was frustration really expressed about the number of iterations and some dumbing down of it. But Jim Mackey still said it was an exciting document, and the reform was still there. So we're likely to see it very imminently. Next slide, please. So part of that is primary care contract reform. Already, the GPs, Wes Streeting was saying at Conferred that, you know, he was really pleased to get a negotiated settlement with general practice, also a negotiated settlement with community pharmacy this year. But actually, it was really notable that there was a letter that Wes Streeting sent to the GPC of the BMA, committing to reform of the GP contract within this Parliament. Same with dentistry. Although there's a big focus on urgent dental appointments, there's also a focus on contract reform for NHS dentistry. And for community pharmacy, there was manifesto commitments to build on clinical services. Obviously, independent prescribing is becoming more and more available through community pharmacy, and new graduates will graduate with prescribing qualifications in next year. It doesn't make sense to do GP contract reform without pharmacy contract reform, and it doesn't make sense to have big ways of thinking differently without looking at the community pharmacy contract, looking at clinical services, medicines optimization, and how we use independent prescribing, how community pharmacy is a first point of call for all of the residents of the neighbourhood. Next slide, please. We had the spending review the day before Expo, and very much the spending review. It talked about 2.8% growth, but I've put the King's Fund diagram of how much the Health and Social Care gets as opposed to other government departments. And it's a huge amount of money, but it's not a very big amount of money when you look at what things cost. If you look at the independent economic analysis of community pharmacy, where the estimates for what NHS pharmaceutical services alone costs in 23-24, it was over £5 billion, although pharmacies are getting paid this or were paid under 3 billion. And by 2030, with the growth in items and inflationary pressures and other pressures, it looks like if we continue with the status quo, the cost just of NHS pharmaceutical services will be £8 billion, and that's set against everything else, all of the other calls on money for the NHS. So there was announced 10 billion for NHS technology and digital transformation. So money where their mouth is in terms of that digital transformation. I think the NHS app has had a lot of investment. There's quite a push for the NHS app to be the go-to place for people for NHS services, and looking at how they manage their care through the NHS. There was a digital front door. And already we're seeing NHS 111 online through the NHS app, so that people can be referred to the right place first time, and often that is community pharmacy. 7,000 more dentist appointments, more GPs, and those claims that we already have more GPs. Mental health support in all schools. and more mental health staff, because there is a crisis, and especially in CAMHS, huge waiting lists. And there was talk about capital budgets, and that's really critical because the NHS has been starved of capital budgets, and capital budgets have been raided when revenue has been overspent in the past. That, I think, will be a thing of the past. There is very little detail on the capital budgets, but we'll see what comes out subsequently. Could I have the next slide, please? So I just picked out a few bits from Wes Streeting's speech after the spending review. So he's very much talking about the 205 billion as what we've got to play with in the NHS, and we shouldn't be playing around the edges with the 2.8% uplift to the 29 billion. Driving excellence, and the centre will be using its central procurement muscle, so very much trying to use purchasing power of the NHS where they can to better effect. So that will be a function of the newly formed Department of Health and Social Care, encompassing some of the statutory central functions of NHS England, and the functions that it makes sense to do once centrally. There was a real a look back to foundation trusts and the success of foundation trusts before the centre started to have more control over them, and saying we need to go back to that kind of model and reinvent that model for a modern age. And a lot of talk about NHS leaders, getting the leaders who perform best to take over failing organisations. Wes Streeting talked about GPs running hospitals or hospitals running primary care. He didn't like the fact that there were meaningless community acute labels. He wants it all to be NHS care wherever that is. And they talked about financial incentives. So absolutely, deficits will not be tolerated. So we've seen everybody have to put in their financial plans to John Mackey as soon as he became the chief executive of the NHS. And there's some perception that overspends were just accepted as a fact of life. And that is very much being challenged. And the challenge is we've got to improve the productivity of the NHS. So there will be financial incentives. So that will be interesting to see how those come out. Next slide, please. So what's community pharmacy's role in all of this? And, it was very interesting that Wes Streeting said much of what's done in hospital today will be done on the high street, over the phone or through the app in a decade's time. And, who have we got on the high street in the heart of communities? We've got regulated professionals, clinical trained, both pharmacy technicians and pharmacists. We've got regulated healthcare premises already there. We've got people who are already, pharmacies and pharmacists are well on the way to being trained as independent prescribers. A lot of people are using independent prescribing for private services already. In fact, most of the expertise for some of the weight loss management in the UK is through community pharmacy services. And there's all sorts of potential developments. So if we're reimagining the way things happen at the moment, why would you go to your GP for some of the things that you could go to a community pharmacy for? In Southern Ireland, we have HRT through community pharmacy. In England, we've got contraception and emergency hormonal contraception already. We need to be using the medicines optimization skills of community pharmacists to make sure that people are getting the right medicines when they need them. We need to reimagine the way we're looking at repeat medicines and how people get their repeats and how often they get them, because there's a huge burden on patients, and patient experience is a real factor in the new neighbourhood focused local NHS. So huge amount that's possible with community pharmacy. And we think community pharmacy will be taking on huge amount more NHS services, and we want to work closely with you on how we do that best. Next slide, please. So in summary, I think we had a operational guidance that supported recovery. We're just about to get a 10-year plan that's going to talk about the big reform, and that will be the really important document for all of us. The operating model is emerging and we're learning, and we need to help people figure out how the parts of that are open to local development develop, and how we use all of the professions and MDTs, because the focus is on integration, which is not working at the moment. Poor leadership won't be tolerated, and neighbourhood health services are absolutely central. So I think they're your takeaway messages, and I think we need to move on. So thank you very much.
Thanks, Jill. Thanks, Michael. So that was really, really interesting, and we've just got a couple of minutes for some very quick questions. And I can see Michael's answering some of them in the Q&A box. If anybody does have any questions, if you want to pop it into the Q&A box, we'll see if we can get to it. A very quick one for you to start with, Jill. So West Streeting isn't the first Secretary of State to have talked about more prevention, more transfer from secondary to primary care. What do you think will make it different this time from your perspective, given that it's been promised many times before?
Yeah, I think this time money will move from hospitals to community, and I think this time people who aren't delivering that will be moved on. And it's very clear that that will be the case. So a huge productivity drive, but absolutely, Wes Streeting keeps saying no money without reform, and I think he's expecting really big reform. But instead of being nervous about reform, I think he's really willing to support people to make really big reform locally. So it's difficult. No one says it's there's no one who believes it's not difficult, but I think and Wes Streeting has agreed it's not an easy thing to do, but actually all the financial incentives and all the support, and he's really put his money where his mouth is in terms of getting rid of some of the central functions. It's a bold move to get rid of NHS England.
Yeah. Thank you. So we had a question here. Is there potential to expand on existing pharmacy first scope as part of the shift to primary care? And if so, what's the likely time frame? I'm sure Jill and Michael both have thoughts on that one.
Yeah, I think it's absolutely possible. The first 7 conditions, and actually it'd be possible to extend the scope of those 7 conditions because they're quite tight. But it was really important with antimicrobial resistance that that was done very, very carefully. But actually, I don't see that there will be things like head lice treatment or things that people can buy over the counter. But I do see where people are being accessing the health service through the general practice route, they will be triaged to community pharmacy for anything that they can be. And independent prescribing obviously makes it much more possible for the clinicians in community pharmacy to take their own professional accountability for managing people who are signposted to them or referred to them in pharmacy.
And to build on that, Gareth, then, I mean, we only have to look north of the border in Scotland to see what an expanded scope, scale, and more appropriate structure of delivery could look like. Our Scottish colleagues, if we transplanted their run rate back into England pro rata, we could be channel shifting probably 7 or 8 times as many people from the front door of general practice. So an expansion scope of what we can deliver, but also the fact that you get proper structured referral, signposting, and walk-in running hot. At the minute, the NHS scheme in England is brilliant. It's made a heck of a difference already. But if we're really going to run it hot and make the difference and free up our GP colleagues, it needs a bit of a rewiring and also a bit of a reimagination and layering on top. There are easily 20 conditions one could imagine. And as Jill says, it's not about supplying bottles of stuff. It's about a clinical intervention. Easily 20 that we could kind of put on the table that would really boost it. But a walk-in dynamic that expands would be helpful as well, beyond just the 7 that we've got at the minute.
Okay. I think this will have to be the last question. We've a few people have asked about vaccine delivery and how the changes to the NHS may alter that. Who wants to take that one?
So vaccines are due to be devolved, delegated commissioning on the 1st of April next year. I don't believe that will stop. I still think the delegation of that will happen. Certainly, there's been a move around childhood vaccinations and pharmacies being able to do some legal changes that makes pharmacies able to do that more. So I think pharmacies are very proven in terms of their ability to provide vaccines. They've been called upon in things like polio outbreak in London. And I think actually because prevention, I mean, you've seen in Texas with MMR, measles outbreaks, it's really important that wherever we can get vaccines into people and prevent some of these diseases, we do. And obviously it has a knock-on impact on AMR as well.
All right. Jill, Michael, many thanks for all your insight there. Really, really interesting. And I'll hand back over to Louise.
Thank you, Gareth. Thank you, Jill. Thank you, Michael. Really, really interesting. I'm going to actually now hand over to Sanjay and Matt. We've only got a few minutes left, so this will be a whistle-stop tour. So, Matt, Sanj, over to you.
Thanks, Louise. Just jump on the next slide for me. Afternoon, everyone. So yeah, like whistle-stop tour of kind of our, I suppose, our offer as the NPA and the way we're working with industry partners such as yourselves. And nice to see some familiar faces on the call and also lots of new ones as well. So yeah, as you can see on the screen there, there's lots of different ways that we're working as the NPA, both myself and Sanjay and the rest of the team, about how we drive awareness of multiple different conditions, new ways of working. You see, particularly in the top right, resonates with a lot of pharma and some of the projects that we're working on currently, and alluded to some of the points that Jill made earlier, is like how we're developing new pathways and services to change the way patients access healthcare in the community. Obviously, we know the drive is to access in the community, and that move from secondary care into primary care, and that's a big area of focus amongst the other things you can see on there, such as like roundtable activity and how we shape changes in policy for the greater benefit of community pharmacy and the patients that they serve. Next slide for me, Lou, just quickly. This is something new, and I'm sure some of you may be aware of this that are on the call and others perhaps not, but this is a new platform we've built with one of our marketing partners, and in short, it's how our community pharmacy members access their local communities and how they market what they offer. But it serves as a digital tool that uses patient demographics to target key communities. Obviously, we know patients in the most deprived areas across the UK struggle to access healthcare. So utilising this as a tool is something that can help to correct that somewhat, and how we speak to those patients, how we reach them and drive them into healthcare up and down the country. But to talk more on that, we can spend lots more time in the future. I'll move over to Sanjay to talk about some of our other propositions, so we don't take too much of your time. Thanks, guys.
Brilliant. Thanks, Matt. So one of the innovations that we've developed recently is also a centralized patient management system. So this helps you to access patients post-prescribing, to support them with adherence, any other advice on how to use their devices appropriately, etc. And again, it's very ABPI compliant as it is post-prescription. And certainly, if you want to know more, feel free to engage and we can explain to you how that works. Thanks, Louise. The other couple of innovations is where we have also animated into patient intervention. So here you can have your patient information leaflet in an animated form. And also this could also be pertinent where you've got novel delivery systems. So that can also be animated as well and sent to patients based on the centralized patient management portal. The other thing that we've also started to develop and play with is around AI training and education. Training and education is going to become a very crowded space with independent pharmacy and the improved clinical opportunities for pharmacy. So what this actually does is provides a robust way of pharmacists and healthcare professionals from practicing their intervention skills based on scenarios that are given to them, and it is based on academic platforms, so it will give robust feedback post-intervention, so healthcare professionals can see how they've performed. Thank you, Louise. So partnering with the NPA. So we all share the same goals, and it's around patient centricity, and also in terms of improving access to medicines and healthcare for patients. To do that, what we've done is we've created a value industry partner program, and we'll share these slides with you, so feel free to look at it at your own time. But essentially, there are 3 key tiers. Thank you, Louise. And the 3 tiers unlock access to insight and support, both from the policy team that you've heard from today, and also from Matt and myself from a pharma opportunities and a pharma challenges and opportunities angle. You can access the NPA's logo and also leverage the NPA seal to help your information land a bit better. You've got access and communication to our members, and you can also have digital presence on our membership hub as well. And the cost for these propositions at various tiers range from £3,500 to £9,000. So if at all you're interested in being a partner, I say reach out to Matthew or myself. I'm more than delighted to talk you through what that includes and the process for signing up. Thank you, Louise.
Thank you, Matt. Thank you, Sandra. A bit of a whistle-stop tour, so apologies for that. The Sandra Matt's details, if you don't know them, are on the screen now. Well, it's been very exciting. It has been a bit of a whistle-stop. There's so much we can talk to you about, which is great. I think I wrote something down from Michael. It's a big, bold changes are ahead in healthcare, and it'd be great if you guys come on that journey with us, and we can update you on sort of what's happening. So I just really want to thank you for attending today. It's been a pleasure for us, and I hope it's been a pleasure and a value for you to join us at the meeting today. This is the first of its kind, and we want to continue to do these pharma webinars. So please reach out to Matt and Sanj in relation to that. Independent pharmacy is growing, so we know that we've got a really big seat at the table. We really want to push patient care and patient outcomes. So you're in the right place, talking to the right people. You will receive a follow-up email following this meeting, so that you can actually reach out to us or members of the team. I really want to thank you again from the bottom of my heart for actually attending today, and have an absolutely wonderful afternoon. Thank you.